Okay, great. Okay. I have a timer naman. All goods. Oh, sorry. Okay. Regular people ought not suffer at the hands of bad incentives and parties that oftentimes find certain things more lucrative than others. The first thing I want to ask is who builds these specialty centers? And we would suggest that in the vast majority of cases, this is often built by governments. One, because you have historical precedent with Ferdinand Marcos and NKTI, or the Lung Center and the Heart Center, all of these things built by him. Second, these things are just incredibly expensive. Often it is governments in developing countries that can incur the costs and oftentimes can import these kinds of technology. But third, even if it's some private degree, it's public-private investment anyway, where projects are started by governments, or oftentimes you have to collaborate with governments for it to be done fairly. The second point of framing, therefore, is the context of a developing country. What do they need the most, and what do they cause? What causes death? I think first on what they need the most, we would suggest it is access. It is the ability to get diagnosed in the first place, which oftentimes is hampered by the existence of specialty centers that oftentimes take away resources from allowing for more capacity for these people to see a doctor in the first place, to get that referral, to get them sent to these centers finally. But what then causes death? It is not things like kidney failure. It is not always things like cancer. For the vast majority of people, it is regular day-to-day like sicknesses like the flu that only lead to their death because of the failures of the public systems to be able to accommodate all of them. And in that interim period where they're waiting in the waiting room, begging for a doctor to say it's your time, they die. Finally, then, I want to just preempt what might come out from opposition, which is they might try to win this debate on research. Here are three reasons why it's just not really relevant in this debate. One, rich sects geographically similar to the Philippines, like Singapore and Malaysia, have very similar incentives, but also therefore the capacity to do these kinds of research. So it's far easier for us to co-opt it as opposed to invest in that kind of infrastructure in the first place. Second, research capabilities are just incredibly limited. So we have to rely on, for example, econometrics as opposed to being able to get samples out to every single part of the country, because even if you create a vaccine, it's unclear if it's good for the general populace. But finally, it is unclear why this is the priority if general hospitals are incredibly limited as it is, and therefore that things that oftentimes already have vaccines still lead to the deaths of individuals. What do we therefore support? One, it is funding that isn't spread out across multiple sectors, but rather in general hospitals. Two, production and shifting of political will towards general hospitals. But three, governments funding directly of general hospitals instead of specialty centers. I want to be clear, because it's a regrets debate, it is enough for us to prove why this has done more harm than good. And insofar as we think it has created massive corruption and killed more people than it should have, we would say that's fair enough for why that is the case. Argument one, the rise of specialty centers are a massive incentive, like distortion that directs funding away from general hospitals. Oh, sige, I'll take your POI.
What are the top three dangerous diseases in countries like the Philippines and Thailand?
So we would say it's probably flus. We would say it's probably like, I don't know, dengue to a certain degree. But what matters is that the vast majority of them end up not being diagnosed because these people cannot see a doctor in the first place. So let's go on. Why is there an unfair focus on specialty centers? One, it's seen as optically better and more prestigious for the government establishing it, and it paints a false precedent that you're moving towards development, which we have seen with the multiple specialty centers that Ferdinand Marcos created. And this is especially impactful in populous countries like India or the Philippines that need short-term electoral gains and very shiny things to show that they're doing well. But second, there's a higher margin for specialty operations, and therefore, because of the perception of advanced procedures and that they can charge premiums, it diverts public funding. So the incentive of profit directs towards specialty centers because politicians can be connected to those who run these centers and therefore benefit them. Third, this is just an easy way for governments to appeal to the urban rich elite who are more likely to be affected by things like cancer as opposed to being existentially threatened by things like the flu. But fourth, since the final outcomes of these things aren't always saving people, but also research which isn't immediately measurable in impact, the nebulous outcomes therefore leave far more space for corruption to happen. What are the impacts then? One, in budget hearings and determining who they prioritize for budget allocation, regardless of whether or not you think there will be a general hospital built, these specialty centers will take a large larger budget of these funds. And our reasons prove an excessive amount of them getting built. But second, this came at the same time where we had shortages in beds in general hospitals and the fact that many people are waiting and waiting. So retrospectively, what this means is, while you might care about the cancer patients who honestly, admittedly, can still afford to go abroad, you have hundreds to thousands to millions of people waiting at the doors of general hospitals, not even being able to get diagnosed in the first place. But third, it causes massive brain drain in these kinds of countries, which is very relevant in countries like the Philippines. On the first level, that perception of one kind of doctor being more lucrative, especially when the vast majority of doctors require a baseline level of income to keep studying, and therefore they tend to come from spaces that encourage them to go to specialized care since it's more lucrative. And again, they come from these spaces that are more likely to be affected by cancer or stuff like that. But second, it's just more expensive, and therefore most medical professionals either have to opt into specialty education to learn a livable wage, or if they cannot afford that, get pirated by US hospitals, which can promise better pay without them having to invest more. And what this means is you basically, like that basically created the massive overloading of the medical systems we see in developing countries at the point in which you have far less capacity and far less manpower. That's the first thing they have to respond to. The counterfactual, therefore, is quite simple. Why does it get better on our side? One, governments don't have the rising trend of specialty centers and thus have to do something else, and they therefore will prioritize general public healthcare as the next most politically impactful alternative, which is obviously better because one, the KPIs of general hospitals are much more quantitative in what they do, which is the amount of people they can save that they can save from dying, the amount of people who they cure. But second, hospitals uniquely need a large amount of money to increase capacity, especially in metropolitan areas, to cater to as many people as possible. But third, that this could have been spent on either more beds or space, or at least better paid professionals who are more likely to care better and not be like overburdened. Second argument, therefore, why this is worse for patients. One, on accessibility. We would suggest on our world, you do more for the average person who have no other alternatives versus on their world where the vast majority who are existentially threatened by a flu or existentially threatened by smaller kinds of things cannot oftentimes access these kinds of spaces. But second, that the vast majority of people who will be sent to the heart center, etc., oftentimes still require the diagnosis from or the referral from a general hospital doctor to be able to get to these spaces in the first place. And insofar as we prove that you have far less of that at the point in which you spend money on specialty centers, there's a clear source gap where it is unclear how people can access any care for specialty centers if they cannot enter general hospitals in the first place. But finally, I want to note that it's incredibly stressful for patients, which is oftentimes they have complex diseases and complex issues which affect a multitude of things. What this therefore means on their world is it's far harder to collaborate and cooperate between doctors and between areas of study, which mean that people, for example, who have cancer, who have far more things that affect them with kidneys, with their respiratory, etc., may find it far harder to therefore access holistic and therefore more accurate care.
Great. Thank you so much for your speech. Calling on LO now. Here.
Hi, am I visible and audible?
You're audible. Yeah, you are.
I'll take PY's your voice. Starting in 3, 2. Governments wants to die on the that the most amount of people that die in the Philippines is out of the flu. It is out of the top 3 diseases. A, diabetes.
Hi, excuse me.
B,
Hello.
hypertension.
Hello.
And 3, kidney failure. These are the long-term,
Hello.
these are the short-term illnesses that people
Hello.
develop because of how the Philippines to developing countries across the world.
Hello.
Hello, can you hear me?
You're very
Hello?
laggy.
Oh shit. Wait. Sorry, we'll try to fix the Wi-Fi. Give us a second, please.
All right, no worries. If it makes it better, if you turn off your camera, that's fine. But
Okay,
if the
we'll
Wi-Fi
we'll fix it.
Okay.
We win. Hello, is it better?
Yeah, that's better. Can you try reading something like the motion?
Okay, I'll try to read the motion. This house regrets the rise of specialty centers in developing countries.
That's much better. You can restart with the speech.
Okay. Do you want me to start now? Okay. Okay, I'll restart. Starting in 3, 2, 1. It is wrong to assume that in developing countries, the only diseases you get are the flu, right? In the Philippines, they're the top 3 things that people suffer from. It is diabetes, it is hypertension, and it's kidney failure. This is the matter that grounds us into the real world, into proving why this frame is the most important. Because this affects the majority of individuals. Because of how you consume overprocessed goods, you get heart disease. Because of how you don't get nutrients, you get and you have stress over work, that is why you get heart diseases, or that is why you get diabetes. It simply isn't true that this doesn't affect the majority of people. But more than that, I think you have to question their own analysis. If politicians really care about winning, why would they only pander to the one rich person who has cancer? It is obviously true that a majority of people go through these diseases, and therefore that is why governments will divert funding into this. But the last thing is that they assume there is an important trade-off that automatically once you fund the heart center, it means that you cannot access ibuprofen or like a fever medicine. But look at their own analysis, right? If you can collaborate with Singapore or other countries to get like heart disease, why can't you also get drugs from them? But also more importantly, these drugs aren't expensive. Ibuprofen is over-the-counter medicine, so you don't need to go to a doctor to solve the flu. So a majority of their case just is the debate, right? It's about what these diseases look like in the real world. I want to talk about what this debate really is, and that leads me to the setup. What does this rise of specialty care centers actually look like? And I think it is driven by the demand of individuals who are suffering from these diseases on both frames. If it is public funding, it's the fact that governments have to respond to the middle class, the majority of people, so they fund hospitals that are required for them, diseases that they suffer from. So I don't think it's majority cancer, but it is exactly heart treatments because so many people suffer and die from it. The second is that it is likely also private funding. And this is incredibly important because there is an incentive also to fill in a gap if there is one in terms of being able to fund those procedures that aren't being funded right now by those corporations. It is getting things like not just in kidney centers, but also centers for malaria and dengue for kids that you see right now in the Philippines. On government side, they do not want to support these kinds of things. They rely on the whims of people across the nation. The second thing I want to set up is what it looks like in developing countries. You can't fund all of these things at the same time, right? They can't just say, oh, you can get it from different countries without actually proving why those other countries will randomly give you heart centers, right? Like it just doesn't make sense. You have to fly there to access that treatment. And that is the important thing. And that leads me to the first argument. Why do you get more accessible care on our side of the house? I'm going to engage on 2 frames, right? Firstly, if it is funded by the government, it is the fact that when you have more funding into these diseases, it is that you can actually access the special treatment that you need versus not having it, right? Because a GE cannot diagnose you with the heart disease that you have, cannot treat you for the heart disease that you have. You have to fly to a different country, even if you get funded by those other countries, even if you collaborate with them. The fact that you have to go out of your way to go to a private hospital versus on our side, when you have that kind of investment, it leads you to being able to address those diseases by creating those specialists, by creating those medicines, by creating those kinds of services. And that is why it is important to be able to fund it.
BOI.
Frame is that private institutions, right? Why is it important that they also fund this? Because I think they're also likely like use their own analysis. It's the fact that lots of people also suffer from these diseases, so you want to fill in the gap, right? And that's an important thing, that competition drives you to compete with other companies who also want to enter into the industry because you want to respond to the demands, not just a niche random thing, but being able to get back your ROI. Because obviously, if it's just one person who has that disease, your whole center doesn't make it worth it. So on our side, it's the fact that you have so many companies also wanting to create heart centers, also wanting to create treatments for things like kidney failure that allows you to drive the cost down. The second is that even if maybe it is some rich people disease, a very niche disease, it's the fact that you alleviate the government from having to cover it, right? Because on both sides, they still have that person suffering. It's the fact that on our side, it's you're able to alleviate the government's burden. You can spread out the government doesn't have to cover all aspects of healthcare. The comparative narrative on their side is that the government is spread too thin. It cannot fund all these things. On our side, because you have a rise in specialty centers, it's the fact that private institutions can also help alleviate that gap. Sure, on our side, yes, we can also get those kind of ibuprofen and over-the-counter medicines, but it is the medicine that is needed to those specific healthcare institutions and healthcare diseases that you also get on our side. Before I move on to the second thing, sure.
How many kidney centers, heart centers, and lung centers are in the Philippines? And even if they are small in number, why do they have significantly more funds and money than any other general hospital like PGH?
Good question. You should answer that in your speech. But also, I just don't understand why this is relevant, right? Guys, the number of transplants gets less on their side. That is the comparative that you were dealing with. The costs are higher for people who go through those heart diseases, and that is the comparative they have to deal with. I want to talk about the second argument, right? Even if it is not accessible, it's the fact that it exists in the first place because they assume they can still get it when that is not true. I want to explain why you get that quality care on our side. Because what are the issues right now revolving around those diseases? One, it's the fact that you do not have that kind of treatment, that you don't have a lot of ways to treat that, right? That's exactly why you need more transplant centers, because there's some treatments that cannot cover pregnant women, that cannot cover certain amounts of people, certain minorities because of a certain thing, a certain illness they have, a certain gene they have, that's incredibly hard to treat. So you create those centers for our side. But the second is that I think it's specifically the context of developing countries where diseases and illness get stronger when it comes to things like developing countries having very specific parts of heart disease, specific kinds of kidney failure, but also specific strains of malaria and dengue that you're unable to cure on different sides of the world. Their comparative doesn't work here because you cannot create a vaccine when it has already affected so much of the world. You cannot just import the vaccine to a different country, right? Because they have no interest in funding that because they aren't suffering from it. In the Philippines here, you are able to create a center for like malaria or dengue that is allowing you to create that kind of solution that allows you to create that vaccine before it even starts to hurt your country. And the last thing I want to say is that even if there is even if that like vaccine or those kinds of treatments exist in other parts of the world, it's the fact that there are patents on them that means that you cannot reproduce it for your own, so you have to keep paying very, very high costs. The second is that I don't think it's like likely that they want to give it to you, right? If you look at COVID, the whole thing is that they don't want to give you vaccines. They only gave it to you once they already were better off. It's the fact that they let vaccines expire. On our side, you are able to create those special treatments that people need to survive. And I want to be very clear. This is not just the upper 10%. Think about the people in your lives who has a heart disease, who has a kidney failure. And I guarantee you, it is not just Jeff Bezos in your mind right now. It is a mother, it is a father. And these kinds of things are the only side that's able to create the solution for these people that are incredibly important and incredibly vulnerable. Oppose.
Thank you so much for your speech, LO. Calling on DPM. Thank you.
Yo.
Wait, just give me a moment. Okay. POIs in chat. Again, just to emphasize very kindly, POIs in chat. All right. Starting my speech in 3, 2, 1. The problem with this government team is that they are fundamentally unlikely to win this debate because they assume a frame that doesn't exist in the context in which they say they went on. They say most people suffer from disease in these places. They suffer from all of these things, and that's the most important public priority. But I want to note, in places like Africa, the most important public health concern they have is things such as, for example, diarrhea and dying from that, not having access to early assessment of things like diseases that they get from food or water, which means that they don't, because they can't afford to go to a hospital in the first place, don't get treatment from that and they die. They have to explain why they get this exclusive benefit on their side of the house rather than the likely most intuitive reason on why public general hospitals are just better for the vast majority of people. I'll do a couple of responses and lastly, an extension on what is the obligation of the state and why we just get that obligation better when we afford better care for more people. Firstly, they say governments will still invest, as a claim from Kara that in trying to start from a semester size debate or limit our impact, still invest in public health care because they say there are popular incentives to do it anyways. First, I want to note, debate is about extents, right? which means that maybe there is some still investment in public national hospitals or general hospitals and some investment in specialty care on their side. What we explained with the four mechanisms that come from Nessie's first argument is that an overwhelming trend of public incentives that are often very cynical, often very likely to prioritize profit or the urban elite, etc., to prioritize massively more than needed to specialty care or to other things in there. This massively detracts public funding because obviously these things are expensive, require lots of advanced technology, and often they are run by the cronies and the nepos that are tied towards people who run these governments. Often they are very shiny projects, which means that the extent to which they get public investment is conceded by Kara is significantly less. But two, I would just want to note, they cannot just say because these are more important incentives. Like, governments can still be bad, guys. Like, they can, be corrupt. And many instances, even if there are public clamor for public investment in hospitals, they can still prioritize private investment, like they do, for example, in India, where often they still do massive amounts of specialty centers, etc., because it is lucrative for their cronies or for the nepos that they have or their very, very shiny projects. It's not about whether or not one weighs out the other in debate. You have to look at reality, and many of them still prioritize this, even though there's over-congestion in public hospitals and many people actively dying on the streets. The second thing they say is, try to win on this disease point, on malaria, and this is the most important thing we have to solve on their side of the house. Firstly, on the research point, here's the nuance. It's unclear why developing countries are demargined to develop this research and necessarily have to bear the burden of having all of this expensive technology, having all of their medical professionals centered around this, because there's a black hole of incentives around specialty centers in the first place. As what we explained from Nessie, often many other countries like Singapore and Malaysia, who are geographically proximate, have the same amount of diseases, and even Western institutions research into these things for public healthcare, etc., or from the WHO. They say, oh, these don't exist. They won't give you vaccines or research because there's patents. One, this is clearly nonsense. Many of them are often research institutions that do it explicitly because they want to create these things for developing countries. Number two, even if they were selfish, there's private incentives for you to sell vaccines, right, to developing countries and, get those kind of procurement, etc., which means that, but number three, like, it's unclear as to why they could just sell these things at like a 1000% markup. Like, that's very, very bad politically for those governments. It's also very, very bad because no one's going to buy it, right? It's very, very expensive for the countries that are literally a developing country market. So there's an incentive for them to still give you that research. It's unclear why developing countries have to bear the burden. The second thing is just, we also solve diseases in general hospitals, guys. The first thing I want to note is that they don't prove as to why these research, specialty centers are the best things to solve diseases. At best, they solve one disease in one particular location, but another location is very, very far away. Often it's very specialized in a different kind of thing, and their side is very, very niche. What is the benefit under our side? One, we have comprehensive care over a wide range of health issues. We have ICUs. We have general admission and medicine for vaccines, for example. It's unclear why they get that on their side when it's specialized towards the kidney diseases, towards things such as, smaller lung diseases, etc. Number two, general hospitals are more trained for general early treatment. Note, they can't say all of the diseases happen because, they just happen, right? Many diseases happen because people don't get admission to a general hospital and get checked and their assessment of their health. This is what we solve when you have preventative care under our side, when more people have more access to general hospitals to solve these things early, before they develop diabetes, before they develop all these heart cancer or other things, for example, on their side of the house, which means that you have to default to the argument that comes from Nessie in that it's more accessible and more people get the benefit under our side. The last thing they say is people suffer from diabetes, they need specialty centers. One, I want to note that even if we have to take this trade-off, the small niche of people that probably can go to different areas to get this kind of specialty centers, etc., like, they already do this, and it's probably going to be the same level of cost because they have, massive amounts of costs in these things for developing countries anyways. So the margin of people that they benefit is the same and very, very small. Compared to our side of the house, it's more accessible. So even if you have to take the worst case trade-off, we are okay with it. What the last standing material that comes from them, they say, well, this is good because now we can, funnel private investment versus other things that they could be doing that's bad. I'm unclear as to what this looks like. You can't credit it because there's literally no building for what these other things they could build on. It is better if you remove the black hole of incentives for the first argument that comes from Nessie, because the most politically salient counterfactual is that they have to listen to the people and get points from the people by investing in more likely cost-efficient things like general hospitals, because they are government and state actors, right? And private actors also. So we clearly get the benefit from that. There's a more ROI on our side of the house for that. Before I go into the extension, POI.
Having more GPs doesn't change the fact that people are stressed all the time because they overwork. People rely on processed goods because they're the cheapest one. So they're more likely to still develop specialized illnesses like heart disease and diabetes.
Number one, I already outframed this with the preventative care that happens under our side of the house, many people cannot access a general hospital and get these early kinds of things before they develop heart disease because of the fact they're so expensive. When there's more public investment into these things rather than a black hole of incentives, it's now cheaper because there's more competition or more ability for you to access these things, which is why we solve your case in the worst case on your side of the house more likely. But secondly, they can go anywhere else, right? You haven't proven why these specialty centers are cheap in these countries. Likely they are expensive anyways, which means I'm not sure how it's the meaningfully different from going to another country or another community to get that kind of treatment. Why do we clearly win on accessibility? States need to give solutions because they have limited resources and they need to give solutions to the most number of people. In the worst case, this is general hospitals, and we proved why they're going to do it because there's a political incentive to do so, because this is absent the trend, they cannot just justify spending more and more these shiny projects. This is better. One, because when we develop these things, these are more likely to be cost effective. We can build more of these things because they're less costly as an individual technology. Number two, we can make people more likely to, for example, go to these things in the first place and create that kind of culture of checking on your own health. But number three, it's just better because more people get beds, more people get things such as ICUs, etc., and more generalized care, which affects a broader range of people rather than like specialized institutions on their side of the house. They have to prove why these things are good. They haven't done so yet. For those reasons, then very, very proud of.
Thank you so much for your speech, TPN. Calling on DLO. Here.
I'm muted pala, sorry. POIs via voice. Starting, if you raise it once, I'll probably just call you. Okay. Starting in 3, 2, 1, go. I want you to actually imagine government's counterfactual because their case is self-defeating. They say that general hospitals are extremely overcrowded and overcapacity, where people have to wait for hours before they get medical care and therefore they die. But then their counterfactual is to condense all medical care to all general hospitals. They take away people's ability to go directly to heart centers and kidney centers and put them through the administrative processes of institutions that have to cater to everyone. So no, it's not true that they remove the congestions that exist within general hospitals in the status quo. In fact, they make it worse. The second thing I want to note under counterfactual is that this debate is about the rise in developing countries. And that means that either one, they still have specialty centers on their side, but not as many. That means that rich people can still access incredibly specialized care, which is a harm they present from NEFI, but that this benefit does not extend or trickle down to middle-class citizens because there's no competition between these care centers at all. Or secondly, there are very few to none, or there are specialty centers that are very few, or maybe there are none of them. Note that we still rely on specialty centers in their world, but we rely on research and care from specialty centers in developed countries like the US, which have the ability to fund massive amounts of healthcare, massive amounts of research that are not nuanced to the problems of people in Africa or the Philippines. So the specialty centers that you get on their side are marginally worse because it only happens in countries that are rich and that do not live and exist in the context of developing countries. A few extraneous responses before I get to questions. The first is that let's look at Nessie's absurd case on brain drain. She says that people are more likely to leave these developing countries if you force them to work in specialty centers, but that the reason is that they have to go to higher education or something. The first response is that the amount of education that you get if you have to move to another country is like a lot, right? You have to take the NMAT if you go. You have to take the medical exam in the US if you want to work as a nurse or a doctor in the US. So like it's unclear what the margin of difference on that analysis is. But the second response is the flip. If there are only general practitioners in the Philippines because you make all hospitals generalized, then that means the cardiologists, the brain surgeons are more likely to fly out to the US where they're paid more and they're appreciated more because you don't create specialty centers for them to actually operate in. So brain drain actually happens worse on their side when there are no specialized centers for these specialized laborers. The second thing that they say is, well, it's harder to collaborate with different doctors. That's not a part of the debate, guys. Obviously, if you have a disease that targets different parts of your body, you will work with multiple doctors. These doctors will refer you to each other. Like that's just not a harm that they can claim. The first question I want to ask then is, what are the biggest medical problems of developing countries? Nancy says it's things like the flu. here are a few reasons why it's not. The first is because many of these diseases are short-term because it's easy for them to be fought off by immune systems and natural bodily defenses, so you don't have to focus on them in your medical system. But then secondly, it's a lot of the medicine used to counter these things like the flu and like diarrhea are over the counter. So it's unclear why you need to go to a hospital or why your stay in the hospital is going to take so long that you take up so many hospital beds within that medical stay. But so we would suggest that this debate actually exists in the three most common fatalities in developing countries by nature of their environment. Things like diabetes, because you eat highly processed food. Things like hypertension. Things like kidney failure. Note that they say that their comparative is things as that we would rather have more preventative treatment because we have general hospital. Because we have better general hospitals on their side. They don't explain what preventative treatment looks like, by the way, because a lot of these things are genetic and genetic. So in the case of India, for example, they're more likely to get hypertension because of the years of colonialism imposed upon them. But if, like, let's say we win the case on, let's say that
POI.
preventative care is important, right? We're more preventative on our side because we're actually able to focus on preventing heart disease, preventing kidney disease, if these things are not generalized and in hospitals where they have to split the budget, etc., etc. Even if like their frame is true, and let's say it's things like diarrhea in Africa, then that just means we need specialized centers in Africa for diarrhea. It means the African government shouldn't have generalized hospitals for people. They should invest in clinics in certain regions in order so that people are more able to get care for their fatal diarrhea or whatever. So that still works for our benefit. The second question, before I get on to specialty centers, I go.
You talk about overcrowding, and don't ignore me this time. How many kidney centers are in Davao, Digos, or the north of Luzon? There's only one in the Philippines. How will you cater to the millions of diabetic patients with one fucking center?
So one, this motion is about the rise. So if you want to argue that there aren't enough specialty centers, then like that's crossing the house. The second question I want to ask then is, what kind of diseases do specialty centers actually address? I want to note that these specialty centers are beholden to investors, just like general hospitals. They're profit-oriented, like government has framed. So it's likely that the diseases they're going to tackle are one of two things. One, they may be very specific, very expensive treatments that only affect the broader, the richer part of the population, things like cancer. The reason why this isn't likely to be the case is because there's no market niche for this, right? There's no market incentive to treat things that only affect the 1%. But even if that's true, that's good because it means you alleviate a lot of the burden of larger hospitals. If PGH no longer has to cater to rich cancer patients, it means that their medical care that they can now give to a lot of people that need public hospitals because they have no other alternative will be much more focused on the diseases that common people actually have, and that's good. So even if specialty centers only cater to a very, very specific niche disease, that's good because it alleviates the burden from public hospitals. The second likely frame is that these are diseases that are very prevalent that affect a large amount of people. And these are the things that Kara explains that they never respond to and just wash out of the debate, right? Things like diabetes, things like hypertension, that are again the three most common and most deadly diseases in the Philippines. Let's take the Africa frame, and say that it's diarrhea. These diseases target specific areas of the body, yes, and that's the specialty part of the motion, but these are diseases that affect the vast majority of the population. That's why it's important to have specialized centers. It's not, by the way, it's not just about like the Philippine Heart Center. It's about heart centers in your barangay. It's about the ability to get a kidney transplant in key areas of Mindanao, for example. These are diseases that affect a large amount of the population, and that's why we should focus on them. For all those reasons, oppose things.
Great. Thank you so much for your speech, TLO. Calling on Gossip. You're here.
Hello. Am I audible and visible?
Yes, you are.
I'll take POIs through voice. Raise it once. I'll remember you. Can I have some water, Nasi? Speech start in 3, 2, 1. The cruelest of ways to die isn't at the hands of a disease, but rather the hands of no one at all. Op's fault in this round is their inability to characterize the true context of this motion. It's telling that Kara wasn't able to answer my POI, nor was Chelsea, because apparently the solution to millions of diabetic people in a singular kidney center in Manila instead of an expanded general hospice that can care for these things in different ways. I'll kill this point in 3 ways. First, explain why their only standing benefit of research is out of this debate. They say here, well-developing countries suffer from diabetes and developed countries don't, which falls to the observation that the fucking United States exists, the literal hotspot of all diabetes research in the first place. Importantly, they can't just say that the main benefit of this is research, then therefore say that it's important, therefore on their side to create localized forms of this. Importantly, the insulin that is created in the United States and Canada can be also used by Filipinos who come from the Philippines. Just because we come from different countries does not make our genetic makeup different. These things will still work on you, especially when you consider that other nations like Singapore deal with things like dengue, which allows for public-private partnerships that allow for those sorts of things to happen. But importantly, you know what? We already solved diabetes. The question isn't how we are able to solve it again by providing a new cure, but rather how are we going to get insulin to individual people? And here's where there's a problem-solution mismatch. They say you need kidney centers to solve diabetes. You need lung centers to solve lung cancer. When importantly, it's not an issue of whether or not we have the cure, but an issue of distribution, which oftentimes isn't available to people because the vast majority of the funds are being funneled towards these specialized centers, as what Nessie explains, and the 4 individual reasons that she explains as to why they're unjustly prioritized over general hospitals. So importantly, they don't even get their benefit of helping out people, insofar as the prerequisite to getting insulin to people isn't a kidney center, it's a hospital and expanded ability to be able to care for as many people as possible. The second thing they say is no, they won't sell it to you. Why? This is asserted. Importantly, their example of COVID-19 works for us. China sold us Sinovac, AstraZeneca. You know how many vaccines the PQA made, the Philippine Quarantine Authority? Hint, it's a number that's less than 1. Importantly, it's so much harder for them to justify why this research will be good in the first place, when oftentimes developing countries don't have the best medical infrastructure. Even if it is localized, that localization means nothing when you're able to do things with a lot of the things that you talk about. But importantly, listen, will this research even be good? Look at what happened with Dengvaxia. Even if we believe that they're going to create something, it's likely something that isn't good. It's likely something that isn't tested to the fullest extent because they don't have enough funds to be able to interact with that research. The upshot of Dengvaxia and them forcing this upon people's throats is literal children dying. I could have died if I took Dengvaxia, but the only reason I didn't is because it worked for me because I got dengue before. And this is the literal margin of the debate. It's not just no research that they have to contend with. It's unjust and literally research that could kill people in the aftermath. What this means for their case is 3 things. Their only standing benefit of research falls insofar as 1, it isn't important. It's an issue of distribution, which we solved. Secondly, we explained that other developing countries have an incentive to want to research into the same things that you talk about, and they want to sell it to you because these are often private corporations that want to sell it to you and make a profit. But thirdly, even if we explain why they make those things, 1, they can't cater to each individual person, which is why the POI asked was important. But importantly, we also explain that the research also tends to be bad in the case of Dengvaxia, for example. The next win condition that we have is on explaining where it gets better for the average person. And here they counter assert 3 reasons why Filipinos die: kidney failure, hypertension, and diabetes. To which I can counter assert 500 reasons and 500 illnesses that are basic why people die in Africa. Diabetes is one part of the pie. They die from things like diarrhea, tapeworm, polio, which doesn't even exist in the developed world in the first place. All of these are easily preventable diseases that can be solved with the expansion and actual direction of funds towards general hospices in the first place. And that was the comparative they had to deal with. Why don't you support these medical hospitals or these medical centers being expanded such that they can intake more people in the metropolis? Why don't you expand the creation of other hospices in smaller regions insofar as a lot of the kidney centers and a lot of the things they talk about are centralized towards certain metropolises? There's only one national kidney center. There's only one Philippine lung center. But at the very least, you're able to direct that money to much better use under our side. But last, it's also about corruption and how much easier it is to steal money in an already politically fragile developing country. It is so much easier to make sure that the dollar that is used doesn't actually go towards saving a person's life, but rather in the pockets of every single politician. Before I go on, I'll take a POI. Sure.
So if governments are so corrupt, they're literally trying to kill people with Denbaksha, why will they fix all the issues in general hospitals instead of just, as you say, prioritizing the elite?
No, 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 no. You don't get to wash this. It's about extents. We explained that it's the fact that general hospices have much more quantitative KPIs that make it easier to take funds, whereas the nebulous outcome and upshot of research oftentimes lends closer affinity to higher government budgets that are being taken by the dean and by individual government officials. We explain it's the fact that in the vast majority of these instances, hospitals and their ability to be politically popular are also what takes precedent in a world where they don't fund it towards the NKTI. So even if there's an equal amount of corruption, it's about where the uncorrupted money goes. And insofar as we also weigh why it just gets better in the comparative, then obviously we also win. On account of all of this, we already win right from the onset. What are the clear impacts? Every dollar that could have been spent to save a person's life in a general hospital ends up going to less efficient, more uncertain, and exceedingly smaller impact values of research. More people die under their side because time is of the essence in medical care, but the prerequisite to getting to these specialty centers are still general hospitals that refer you. Just because you are feeling pain, you don't know whether or not that's within the kidney center, you don't know whether or not that's within your heart or within your lungs. Importantly, you need general hospices in order to be able to diagnose you, which means that our case is prior to them in every conceivable outcome and circumstance, indicating that there's already a risk of people dying under their side. But lastly, listen to how unrealistic their claims are. They're going to save and rid the Philippines of diabetes because we have a kidney center. They're going to save and rid us of all of these different things because we have these centers of research. When they neither provide the burden, it's far too late for that at opposition whip, which is why clearly from government whip, we're already proceeding. What do you get at the end of this debate? There are 4 standing impacts. The first, we simply explain why there's an unjust prioritization through the 4 things that come from NESI that essentially ensures that in every single government proceeding, general hospitals will always have a smaller cut of the pie. There are incentives because it looks nicer on your resume. Second, it's also about ensuring that people get access to the most basic of things before they're able to move up, but also things like blood thinners ensure that the risk of things like diabetes are also smaller, so we're able to co-opt that benefit too. But thirdly, it's also about the ways in which people interact with these medical centers, how they perceive the government, and how that gets better always. For all of these reasons, it's an incredibly clear government win.
Great. Thank you so much for your speech, Golfwhip. Calling on Golfwhip. You're here.
Hello, can I am I audible and visible?
Yes, you are.
I want to make 3 strategic call-outs on side government. The first is that this is a regrets debate, and note how none of the 3 speakers today prove why their counterfactual is true. It's unclear why is it the case that there's just less corruption because the urban elite will exist on both sides of the house. It is unclear why on their side of the house suddenly there are just more investments and there are more medical professionals when they agreed and they conceded that GPs often are paid lower. So logically, there should be lesser medical professionals and or either more of them go to other countries where they're more likely to be appreciated. By the way, the extension that was not responded by Sam, so it's still standing. The last thing is the comparative isn't comprehensive healthcare, right? Because we're operating on the same number of resources that most developing has. The counterfactual then is on government sides, it's GPs and lower level practitioners that and general treatment plans that can't diagnose or treat specialized illnesses that actually afflict the masses of developing countries given their lifestyles and given their genetic predispositions. The second thing is the response to a lot of what we said is that there's a private incentive to sell treatments and the like. Note that this works against their side. So this game of extents, right? We would say when it comes to general illnesses, there's already more competition because these are illnesses that are also affected or afflicted in people from developed countries. The problem then is that they are able to monopolize diseases that only affect a few countries. And that's why it was crucial for developing countries like the Philippines and Thailand to initiate their own research on diabetes through specialty clinics. Because without this, they are heavily reliant and beholden to China and the United States, whereas the same thing cannot be said for fever and diarrhea because these are research that's prevalent in different countries of the world anyway. The last thing is on accountability. And the response from Sam is there are a lot of KPIs. I want to make this flip. There are clear KPIs in specialty clinics because they're meant to target specific diseases. On your side of the house, there are literally different sectors and different things that they have to address. And that's why it's easier for politicians to muddle government budget and funding. That's why PGH had the highest levels of corruption and had like a lot of sketchy books compared to other hospitals that are government run but are more specialized. The first issue that I want to tackle is what types of diseases do we really want to address? They said that it has to be mild illnesses. We gave you structural reasons as to why this is not the case. The fact that these illnesses are to begin with easier fought off by your
POI.
immune systems later. The fact that these drugs are OTC, which means that you don't even need to be diagnosed by these things. That the fact that you don't need doctors to be treated, and these can often be treated at home. Therefore, the types of illnesses that you want to prioritize are ones that do need specialized practitioners, but are ones that are afflicted by the vast majority of individuals that are common. So things like kidney and diabetes, right, are prevalent because people are reliant on processed foods and salty foods. They are highly stressed because if you're middle class or lower middle class, you have to work for long hours and shifts, right? They say that we have preventative healthcare, but number one, they don't explain this. Number two, they're inevitable because they're lifestyle and genetically predisposed, not exactly tackled by your GP or going to a doctor. They don't actually mechanize this. But lastly, we do this better because we have different facilities that focus on different specialized illnesses. They're able to focus and get to these treatment plans and preventative healthcare plans faster. That's why the progress of research in different areas were more pronounced. The comparative on side government bench is maybe until now we don't have alternative treatment plans for things like diabetes and heart attacks, even though they affect like more than half of the Philippine populace and people from other countries. Before that, POI.
So this is still a false dichotomy. We clearly have comprehensive care and ways in which we can solve these things under our side, like medicine and ICUs and other things that are comprehensive and integrated within general hospitals. You have to explain why specifically isolating them to disparate centers is better way to solve the millions of people that likely will be affected on either side.
No. That is, the math is not clear because on your side of the house, you're spreading all of these resources thin. Like you can't multiply the Philippine budget times 10, right, and give them all to these hospitals. What you are more likely to have in your side is no hospital being able to address diabetes effectively or heart diseases effectively because they weren't able to have sufficient funding into the research, into the paying these doctors, and into the treatment plans to treat these patients. So it's all half-baked. And as what Nessie is established, it's GP. So I'm not even sure if you're able to have comprehensive healthcare plans. By the way, this is also where I want to call out again. They have an unclear counterfactual, and that's why they cannot win this debate. The second thing I want to talk about is on access. The first one to then engage is in the corruption case. Note how on either side of the house, corruption is symmetric. It's unclear why the elite suddenly will become more benevolent and more democratized on their side of the house. It's about extent. And I would say that it is far more harmful on government bench, right? Why? If the urban elite will lobby for specialty centers on either side, it is more, at least on our side, we have more hospitals funded because of the rise, right? Without the rise, only 2 centers are going to be sufficiently funded. With the rise, at least 10 centers are sufficiently funded. And this is good because if the urban elite, even if they're the ones who make the most use of specialty clinics, it's a fact that they're not sick all the time anyway. So what matters is the number of hospitals that are funded on their side of the house. If it's only 1 or 2 specialty clinics, given that the urban elite will still have a lot of power and a lot of say in domestic politics in developing countries because corruption is prevalent, the difference then is the number of hospitals that the public can access, and it's way lesser on side government bench. The second thing is, as we explained, that there are different types of treatment plans. They said that what matters is we have one treatment plan accessible to all people. This is just untrue, given that, as we said, there are people from different demographics that will not precisely work for them. People like children, pregnant women, people who are disabled, people who have certain lifestyle things. Like you can't just give insulin to people who are below the age of 60 or 50 because this will ruin some of their body systems, right? Or the fact that this compromises compromises you, or the fact that you cannot work because some of these things require you to be bedridden. But the last thing is we're just able to cater more people. The reason why we can't have comprehensive healthcare in a lot of developing countries is because precisely their budget is limited. And that's why the problem that side government says, where there are only specific illnesses that are prevalent to a lot of people, like things like diarrhea, is precisely why we would have rather that governments focus on treatment for diarrhea, because they they afflict more people. On their side of the house, they want to focus on money on different diseases, even though we're not sure if these different diseases affect a lot of people anyway. We think on side government bench, she wastes a lot of money. But on our side of the house, every dollar is guaranteed to go to these people. Given that governments respond to voter incentives, and if governments tend to be corrupt, it's a number of hospitals that are then funded. And that's why on our side, we're very proud to oppose. Thanks.
Thank you so much for your speech, Upwhip. To finalize your case, calling on Upwhip line. You're here.
Starting in, wait, I'll just open my recording app. All right. Starting in 3, 2, 1, go. There are 4 lies that you have to believe from government for them to be able to win this debate. 1, that politicians are incentivized by voter interest and the visibility of their projects because they need to claim their impact to the people, but also that they create specialty centers that only cater to 1% of the population. 2, that there's congestion in public hospitals, but the solution is to put everyone in public hospitals where they have to compete with one another under the same administrative processes with the same, for the same beds and the same treatment and the same doctors. 3, that we don't want to over-congest public hospitals with rich patients that can afford to go to good doctors anyway. But you take away the specialty centers that these rich people go to, therefore they have to go to places like PGH, which congest even more. But fourthly, they say that developing countries are poor, but somehow in their counterfactual, they multiply the national budget and can tackle all diseases all at once in all hospitals in the Philippines. Clearly, this government team is not debating with the nuances in the context of the debate. That is why they have to lose. The first issue in this reply is, where do we get more accessible medical care? Cara presented 2 things. 1, that you can't fund all diseases, but you can increase the funding that you allocate to important ones. So maybe it's diarrhea in Africa. But then the solution to that is you create specialty centers for diarrhea patients in Africa. If the top disease in the Philippines are things like kidney failure, you create specialty centers for kidney failure so that you're able to tackle the disease more precisely and you're able to create solutions that are accessible to everyone. Because the problem in the status quo is, yes, as Sam correctly points out, that we already have like things like insulin from the US. The problem is that these are from developed states that do not have the nuances of the Philippine economy, and therefore they price it so much because they have to export it. And 2, these are things that sometimes don't even cure the diseases that we have. These are things that are created that are created to fight against strands, for example, that may be present in the US but are not present in states like Africa. So I'm not sure why their solution is just to generalize medical care for everyone, when clearly there are diseases that are more important than others, and that's why we have to tackle them through specialized care. But the second thing that Cara says is that the competition between general hospitals and between medical centers, the competition, in fact, between different medical centers drives down the cost because of the fact that there's a rise. It only happens when there are more of them. And therefore, even if on their side, they have very, very few specialty centers, it's the fact that a transplant costs so much because you can only get it at the one transplant center in your country. On our side, you can get it at multiple hospitals, at multiple centers, and that's what makes it cheaper for everyone. So if they want to win this debate on access, clearly access is more manifests more on opposition. The second thing I want to note is, where do we get more quality care? I want to note that they never respond to this. They just wash it out and say that it's not important because we don't need quality care in developing countries anyway. Look at the Philippines. It's a developing country and we don't have quality medical care. Maybe yes, we do have a lot of pharmacies that create that sell over-the-counter products for diseases that are very, very common. But we don't have quality medical care for people suffering from long-term, specialized, and very, very common diseases that we've presented in the debate. And that's why it's important, because these people are people that are suffering. These are not just the 1%. These are people like your mothers, your fathers, and your brothers that are all affected by things like diabetes, by things like kidney failure. And that is why we have to give specialized medical care to them, even if it costs a lot. At the end of this debate, there are contradictions in government's case that make it impossible for them to win, and that is why opposition has to take it. Thanks.
Thank you so much for your speech. To finally end this debate, calling on Gov Reply. You're here.
Okay, hi. For you to give opposition the win, you have to believe in an alternate universe. That most people are genetically predisposed to niche diseases like kidney disease, and that COVID-19 didn't happen, and that the only way to get solutions is to spend on that expensive small impact center. When we clearly explain that generalized comprehensive care is still empirically has been good solutions for this, both preventative and early diagnosis and pediatric care for jealous extension, but also just literal health solutions like procuring medicine, procuring basic ICUs, procuring vaccines. They lie when they say these things are so expensive, when they are basic general hospital procurements that save lives. They have to prove why the care is so dearly needed when it's specialized, but they never do. The first thing I want to point out very clearly is just specialty centers are by design not accessible, and that's clearly very clear by the end of the debate. A, it is limited in accessibility for people outside of metropolitan areas like Manila. And Chelsea tries to throw this out by saying that this debate is about the rise, so there will be more. But that's disingenuous because this is a regrets motion, meaning that they needed to defend this rise as it happened, not how it could happen, which means that one, that doesn't respond to that accessibility point, but two, notably, we explain these things are just structurally expensive when the care for these diseases are not integrated in general hospitals but in advanced centers that are separate, and they likely charge premiums which make it significantly more expensive. But second, if you believe this claim, this therefore comes at the cost of general hospitals. Because by the way, to get the full impact of their claim, you have to believe that every city builds a specialty center for every little thing, and then you blow up the Philippine budget. But second, on accessibility, giving out care from these specialized centers still rely on accessing general hospitals. And this is empirically true because this is the only reasonable way that these places can get quality care to people who, as they claim, are on the brink of death or very high risk, because you will only be able to go inside a specialty center if a different doctor, oftentimes in general hospitals, refer you. So their best case relies on people going directly to these specialty care spaces. But as we explain at PM, people don't usually know what's wrong with them, so they can't independently decide. And what this means is you run the risk of more death for the extra 15 people this heart or oncology specialist has to see because someone saw on WebMD that they might have cancer or heart disease. People who actually have those diseases deteriorate, don't get quality care, and therefore die or suffer in the interim. But so very clearly we win our obligation. But second, it's about state obligation. And this is important because the empirical evidence suggests that many of these specialized hospitals are funded with taxpayer money. So we told you that these countries have limited resources, so there will be a trade-off when you build these expensive specialized centers in the expense of general hospitals. But second, the winning side of this debate is one that benefits the vast majority of people, which we explain, that every dollar could have been spent to save a person's life in a general hospital ends up in less efficient, more uncertain, exceedingly smaller impacts of values of research, but that more people die because time is of the essence in medical care, but the prerequisite to getting to these specialty centers are still general hospitals that refer to you. What we explain is that the comparative of building more hospitals to be redistributed saves more lives, because in the time and with the budget spent for specialty hospitals, we could have just spent them on general hospitals. It's quite simple. We save time for people's conditions to get worse, which means on our world, you actually prevent, for example, people only getting medical attention when it gets worse. And also, we have to look at the retrospective of COVID-19, that millions of people, in fact, died in the waiting rooms trying to get a doctor for the flu, as opposed to diabetes, as opposed to kidney. So if both teams agree that saving as many people as possible is important, it is clear that our world is better. Because there's less specialty hospitals, yes, but more general hospitals that point you to where you need. So maybe there is congestion, but the margin of change is where, which is that in our world, people get medical attention in the first place. In their world, people die while waiting. A couple of things I want to clarify. One, they don't respond to brain drain properly. It was not to say we force people to become specialists, but by design of deprioritizing these general hospitals, you encourage more medical professionals to leave and worsen the medical industry as a whole. But we also explain that the experience of patients is terrible. To go from clinic to clinic when most diseases aren't inherently isolated, to have to spend more time and money on that are all things that enhance the suffering of these individuals, and we think that that is regrettable.
All right, thank you so much for your speech. That ends the debate. You may now virtually cross the house. Again, congratulations on making it this far. The panel and I will be deliberating in Discord.
Thank you.